Hi, welcome to another episode of Live Homage web series. I am Kavita, your host this week. On today's episode, we'll be distinguishing between mental illness and dementia with Professor Dr. Shahrul Bahyah. Professor Dr. Shahrul Bahyah is the consultant geriatrician at the University of Malaya. After completing her geriatric training in Wales, she returned home to Malaysia and had played a key role in research and clinical education of the elderly and geriatric care in Malaysia. Okay, doctor, maybe you can share a bit with us what is the difference between mental illness and dementia?
Thank you again to Homage for the kind invitation. I always enjoy these sessions. And hopefully, at the end of this, we can have some questions specifically from the audience. Well, there's a big difference between mental illness and dementia. While mental health, it is not a mental illness. So, therefore, it is very, very important that the specialist is brought in to get a proper diagnosis, a correct diagnosis of whether it's mental illness or dementia in the elderly, so that it can be treated properly, because the treatments are sometimes a bit different depending on what the presentation of the illness is.
Okay, so doctor, maybe we can go for a second question. What is dementia neurological or psychological?
Okay, so as you know, for those of you that followed the last session, dementia is what we call an umbrella word for a variety of causes, like Alzheimer's, which is the commonest, stroke-related dementia, a mixture of Alzheimer's plus vascular or stroke-related dementia called mixed dementia, Parkinson's disease, frontal lobe dementia. So many different types of dementia, and all of these dementias cause neurodegeneration. So it's a neurological, a brain degeneration. So you lose neurons, it atrophies, it dies. So there's cell death occurring in the brain. Whereas with mental illness, there may be for a variety of reasons, in that it's it is either an inherited trait, or maybe an environmental exposure, for example, trauma, stresses, any inflammatory conditions, toxins, alcohol, etc., that might bring on about mental illness. Or it can be due to an imbalance in the brain chemistry that affects the neurotransmitters, so a chemical imbalance. So those are risk factors. But with dementia, whilst it's a neurodegenerative, it can be termed as neurological, but there are some psychological aspects that are affected as well, because those who experience dementia may have different social environments, and therefore you may present with more psychological or psychiatric symptoms of dementia. Yeah.
Okay, doctor. Actually, now we will move to our third question. Which mental illness is commonly mistaken for dementia or seen with dementia in elderly?
So a lot of patients who present to me in my clinic with a bit of forgetfulness, when you take a bit more time looking into the history, a lot of them, about nearly 50% of them, have symptoms of depression, which is a mental health, or which is a mental illness in itself. So they present with extreme sadness, hopelessness. They may start becoming a bit apathetic, disinterested in people, don't want to go out anymore, they're not doing their usual hobbies, etc., not wanting to see the friends. Some of them can be more irritable, a bit more withdrawn. So these are signs of symptoms of the start of dementia, but they present itself as depression. But there are also those who have dementia that go on to have more, not so much memory loss, which can cause confusion, etc. Some of them have more behavioral changes or psychiatric symptoms of dementia, such as paranoia, delusion, thinking people are out to get them, stealing from them, hallucinations, hearing or seeing things, etc., which make people think that, oh, okay, this is more a psychiatric thing, it's a mental illness. But that's where it's important to, if it's in the elderly, you must make the uh, correct diagnosis, so that you can get treated appropriately, because a lot of the risk factors for dementia, for example, someone with Parkinson's disease, is Oh, we had an interruption just now. Yeah, you all can hear me again. Sorry
Yeah,
about
yeah,
that.
you're
Not quite
right.
sure what happened. But
Yeah.
so yeah, so back to your question. What kind of dementias can present with mental illness, right? So
Mhm, yes.
some dementias can be mistaken for mental illness. For example, if it's late onset schizophrenia, meaning you get it after the age of 45, or late onset bipolar disease. So they present with maybe agitation, suspicion, delusions, paranoia, etc., or maybe manic symptoms. And schizophrenia, if they are having more symptoms of hallucinations, paranoia. So that can still happen, and it may not necessarily be dementia. So it's a very, very important for whether it's a psychiatrist seeing or an elderly care or geriatrician seeing or even a primary care doctor to actually take a proper history, because the risk factors and the history taking is will give us a clue as to whether this is more of a cognitive problem, a dementia related problem, or is this a pure mental illness. Sometimes the treatment is about the same. Depends. If you are having dementia, you present with depression, we are more likely to treat you for depression first, because that's the more pronounced thing. And if you come in and you have dementia and you are coming in with hallucinations, agitation, we may treat you with the psychiatric drug first in order to bring that down, and then do the investigations at the same time to look into risk factors of the dementia.
Okay, thank you. What is the most pronounced symptoms of depression for those living with dementia?
So, as I mentioned earlier, aside from being very, for those with depression and dementia, very sad, being withdrawn, not wanting to see friends, becoming a recluse, because if they are more forgetful, they can't keep up with the conversations that their friends are having. So they, for example, don't want to go to parties anymore. They want to go to kenduri, and they tend to be a bit quiet. And then people are saying, "Hey, what's wrong? What's wrong? What's wrong with him?" So it becomes a bit of a stigma. So they become more withdrawn. And then if they're depressed, depression can also come with anxiety, like every little thing. If there's any noise in the house, somebody doesn't, the children or husband or wife doesn't come home on time, so they become more anxious. So it's a general anxiety and depressive disorder. Some of them might not sleep so well, eating, appetite loss, all those things are some of the presentations. And it's important to treat, because if it is just pure depression, if it goes untreated for over a long time, then the depression may turn into a dementia over a period of time. So, in any older person with depression, we must take it seriously, because it can lead to a change. About a third of people who suffer from depression in old age, due to social isolation or from any other reason, they have a risk of developing dementia if untreated.
So, Prof, is it this bipolar and schizophrenia also linked to dementia?
Well, again, with schizophrenia, is an alteration in the brain chemicals. It affects the neurotransmitters. Um, there is some overlap, but it is different. There's a different pathophysiology. So we can't really say that it is similar. But things like functional MRIs, PET scans can actually differentiate, which is why it's important to actually see a specialist and get it sorted out, and see what really is going on. And I think the advances in psychiatric care, psychological medicine in Malaysia has gone from leaps and bounds from what it was before. And a lot of doctors are aware that, it used to be that all dementia patients get sent to the psychiatric ward, which is very, very distressing for the patients, because they're elderly, they may be more confused and have underlying medical issues. And if you're in a psychiatric ward, you may not be attended to the same way as if you were in a medical ward, because the nursing needs are different, etc. So there's a lot of misdiagnosis before there was a bigger awareness on what dementia is about. Everybody will, if you behave strangely, oh, you're mentally ill, you've gone mad, but it's in fact a dementia.
Okay, how can the caregivers differentiate a mental illness and early sign of dementia in their loved ones?
Well, this is the thing. You're not meant to differentiate. You're meant to see the doctor. So if there is a if there is an issue, if there is a concern, seek help early is the thing, because if they are older and they've got, say for example, diabetes, heart disease, have had a stroke in the past, have Parkinson's, have got generally ill health, and they're starting to become forgetful or have a change in behavior, it's more likely to be dementia than a mental illness. Yeah? So there are sort of telltale signs, and sadly, I've had patients caregivers who have said, "Oh, it's tapa dia dah tua, they are getting old already. It's normal." When in a 60-year-old, when a 65, that's not normal. So we tend to, we used to get pensioned at 55, now 58. Hopefully by the time I retire, 65, because I want to work longer. But we tend to celebrate old age in a way like, oh, dah tua, but then you become old before you're supposed to be, and so it becomes normalized. Forgetfulness is normalized. It's not normal. It should be checked, because even those with diabetes, uncontrolled sugars, who have coronary artery disease, heart disease, if they're starting to get forgetful, is because their circulation to the brain is not so good. So they do need a health check. They do need to be treated properly before this progresses to later in life, or maybe earlier in their case, dementia. It's becoming all too common in our, Malaysian sedentary, love to eat out all the time, grab food every day kind of lifestyle, which I'm telling myself as well. Yeah.
Okay, Prof. So we'll move to the next question. What support is available in terms of mental health in elderly, particularly dementia and the symptoms related to the condition?
Okay. So, for the very reason that Homage is doing this kind of education and awareness, this is a kind of support as well. This lets you know what it is, understand what the condition is, and when you need to seek help. So that in itself is the support. There are also other NGOs. Hello, can you hear me? Can you hear me?
Yes, yes, I can hear you.
Okay, so there's also some NGOs like the Alzheimer's Disease Foundation in Section 11. There's also different Alzheimer's Foundation in different other states, in East Malaysia, in further up in Penang, in Butterworth, in Taiping, wherever you are. So it's starting to sprout. The GPs in the community should be able to, because they have a clinical practice guide that's in every clinic kesihatan. They will have information on how to access a memory clinic. And now we have quite a number of memory clinics. I was in the first memory clinic at University of Malaya Medical Centre, PPUM, back in 2005. We set up the service. And at that time, in those days, they used to sort of put it out on the radio, and then they triage you, and then they say, okay, where's the closest hospital that you could go to? Now we are actually wanting to train the GPs, the primary care doctors, to actually assess them early, because everybody is coming to the specialist, but a lot of the work, a lot of the prevention, a lot of the advice can be done in the community. So, we shouldn't be just rushing to see the specialist. We should actually make sure diabetes is excluded, blood pressure is controlled, exercise, good nutrition is being given and advised. And then if there are still very bad symptoms of forgetfulness, then the GP should refer to the closest memory clinic. In the Klang Valley, there's already quite a few. There's Selayang, there's HKL, there's PPUM, and there are also private geriatricians that see this, and some neurologists that also assess. Yeah.
Okay, Prof, this question is actually from me before I open to the audience. Is it advisable to give sleeping pills at night to the dementia patient?
Okay, sleeping pills is never a good idea, for even if you're well, because it has depends on the type of sleeping pill. It can cause somebody with dementia to become a little bit more addicted to it. And if you stop it, for example, you may have withdrawal symptoms or dependency. They may become a little bit more tired and therefore at risk of falling, dizzy. And then for those who are on it long term, they may also be at risk of becoming more confused. And I know for a fact that sadly, some of my colleagues in general practice give things like Xanax. Even, my God, it used to be a very bad practice in the past where they used to give drugs like Domicum to the elderly to sleep. Domicum is an anesthetic drug. There's been really nonsense going on in terms of practice just because you need to get the person to sleep without investigating why the person is not sleeping. So we have to be very, very careful. So as caregivers who are listening in, don't rush to get a sleeping pill. Find out why is your older person not sleeping. Usually being agitated at night, what we call is a condition called sundowning, where alteration in your brain chemicals are reversed. It causes more sleepiness during the day and agitation and alertness at night. So sleep disturbance. So what we need to do is try and slowly reverse it. And usually they're more agitated if there is more activity going on at night than during the day. So we need to be careful. We need to also look and see whether they're agitated because some of their needs are not met. Say they need to go to toilet very frequently. We need to make sure and see that we reduce that frequency. Tend to give more water during the day. We may also think about whether the older person, because they eat so little, they might be hungry at that time of night. They might need a drink. So looking at unmet needs, or that they're uncomfortable, they're in pain, so we need to actually look into what are the key reasons why they're extra alert and agitated or anxious at night, and then look into maybe non-pharmacological, non-drug ways of calming them down. So giving them a warm drink, talking them down, soothing, dim the lights, making sure the temperature is okay, gentle massage, give them something to eat if they want, maybe even lie on for a little while and then get them back to bed, but in soothing tones. Don't challenge them and say, "Oh, wait, why are you awake? Why you can't sleep?" etc. And then, of course, you'll be calling the doctor next for some sleeping pills. In very acute situations where they're really aggressive, they're getting very, very uncontrollable, then yes, we may give something, but it should be short term and in the interim until we find out what is the reason behind this. Yeah. So sometimes we do give antipsychotics to calm, to reduce anxiety, especially if they're getting very scared and very violent and seeing things that aren't there, etc. So that might need to come in, and then we calm them down, and then we start with other dementia drugs to actually try and balance it off. Yeah.
Okay, so I will open some questions from the audience, please. Hi, Prof. What tips do you have for caregivers caring for seniors with dementia and are also diagnosed with depression?
Okay. That's a challenge for any caregiver, yeah. Because not only are they forgetful, but they're also a bit more withdrawn, depressed, not wanting to do things. So, I would say that one, understand the situation. Of course, already get the assessment by geriatrician or memory specialist or geriatric psychiatrist to treat the depression if possible. But actually, try as much as you can to involve the older person in their basic care. Get them to be more independent. Get them to do things with their hands. Get them busy during the day. Because if your mind is going on repeat, start, repeat, again, then the symptoms don't get interrupted. So it's to actually distract them, animate them by way of song, relax them by way of massage, anything that takes their interest. Go for short walks, take short drives, a mixture of things that only you as a caregiver know about the person that you think they would like. Yeah. But if it's already affecting the depression, it is affecting that they don't want to eat, they're not sleeping well, etc., then it's time to see the doctor to see what's going on. Is there any underlying physical issue? Is the sugars if their diabetic sugars are unstable, that might cause a little bit more of a low mood. Are their blood pressure a bit too tightly controlled, is low, so it's making them a bit more tired, etc. So you basically need a medical health check as well at the same time.
I hope Deborah got her answer.
Yeah.
Okay, the next question from Vivian Tay. Hi, good afternoon. Was it common an elderly not sleep for few days and few nights?
Okay, it's not uncommon, but it's not too common. For those that are not sleeping for a few days and few nights, I mean that is sometimes a vicious cycle for some, because especially around the full moon, there might be certain times where somebody with maybe a behavioral and psychiatric syndrome of dementia may suffer from insomnia and agitation. So and this carries on to the day, and then they become so exhausted, and then they'll sleep for another whole day and then get up again. The bad cycle goes there. So we need to actually, one, do a physical check, make sure there's no underlying urinary tract infection, pain, swollen joint, or anything, to ensure what's causing all this, because it could be a bit of a delirium that's underlying the problem. So but if it's something that's happening every month, every week, then you probably need to start on some drugs to actually calm the person down whilst you do the physical checks. Make sure it's not a urine infection, make sure the bloods are okay, any underlying illness is stabilized. And because the reason why this can happen is also because people with pre-existing dementia, they can go into a delirium. So if they've had recent trauma, they've had a fall, they've gone through a bereavement, a change in circumstances, if you're bringing them to different children's houses every now and again, like a latchkey kid, they can also be a bit disorientated and therefore more agitated because they feel unsafe. So when that happens, I think you've got to calm them down, make sure that they feel safe, reaffirm that they are where they are, talk in hushed tones. If they're going up, you come down. A lot of things that may need to be looked into. But if it's going on for too long and no underlying issue is identified, then you probably need a drug in there. But we have to be very careful with which drug, and because the minute you start drugs, you're going to be dependent on it. So you've got to actually work with the doctor to taper it down, because it's not a quick fix. Everybody wants a quick fix. It doesn't work that way, and the older person suffers in the long run. Sorry, I hope that answers the question. Very long answer.
Yeah. Okay,
how
from
to
Kim.
reverse sundowning? Natural remedies. So how to reverse sundowning? Any natural remedies? Good question. Very good question. So it is to understand why sundowning occurs, firstly, and that is because of the alteration in the brain chemicals. So it causes, a reversal of sleep-wake cycle. So what one of the general things to do is to ensure that, from basic things of making sure that the windows, the person knows that it is morning time, that is, bright lights, open the curtains, make sure that they are aware that, it's daytime, get them up, get them to eat, get them to participate in their activities of care, and basically stimulate them more during the day. So whether it's through exercise, through music, through massage, through activities that could actually distract them. And then by the time it comes to 4, 5, 6, then taper it down. More relaxing activities. Towards time for sleep, then make sure there's no loud music. TV should not be blaring out. Time for bed. Make a big play of, okay, it's time for bed. Let's give you a nice massage. Let's get you in bed, etc. Natural remedies would be things like, I often give my patients who may, despite all the things that to help them that I mentioned earlier, I would give them a bit of melatonin to start at 3 milligrams at night, and then try that for a month or so, or 2 weeks or so, and then push it up to 5, so that it tends to regulate sleep a little bit better. Sometimes it works, sometimes it doesn't, but everything's worth a try. Another thing that I find is also fluid and food intake. So if they're a little bit more agitated and things, you just need to sort of review, what are you giving them to eat? Is it more sugary things towards the evening? So you need to cut that down. It's like having a child as well. You need to sort of beware of what foods may not stimulate them at the wrong time of day. Make sure that they are actually not going to bed hungry because they have a very light dinner. You give them something at 6 and then nothing until the next morning. So they're going to be up by 12 and they're going to be hungry, but they can't express it. So, and then they become anxious and agitated. So it's a few things about learning the rhythm, the biorhythm of your loved one. Other natural remedies, some people give some calming tea, some chamomile, massage, aromatherapy, putting some lavender on the pillow, so many things that we could do. But I also tend to do a bit of everything with some melatonin on board. And failing which, if they are very, very agitated and we've not found any underlying cause, then we need to hit them hard to actually reset the button, get them to sleep for a few days at the right time, and then slowly withdraw the pills after. If things like that are possible. Okay, I hope that answers you, Kim.
Okay, from Tina, non-stop spitting, how can this be stopped or reduced?
Okay. Again, that might be kind of an acquired, what we call tic, or when somebody spits or has a lot of, it could be because they are producing a lot of saliva. So you need to also check what drugs are they on. Is it causing them to hypersalivate? Is there an underlying gum disease or some denture problem that's causing a lot of saliva buildup and then getting them to spit? If those are okay, then it's probably a behavioral side of things. Then you probably may be to stop them from spitting, you might want to give them something to chew, something in hand, to actually try and I'm not suggesting that you give for babies with gums problems that they chew on something, but that might be one of the ways in which to help. But if they have something to chew or something to eat, that might sort of stop that. If the spitting is not distressing to the patient, then it's usually more distressing to people around them, right? Yeah, so it's quite a balance. So if you may not stop it, you might want to reduce it. And sometimes when patients with dementia do things repetitively, is usually because their mind is idle. They're not distracted doing things or chewing things or doing things with their hands, distracted with certain other activities. Then if they are, it might reduce some of those repetitive things that they tend to do, like asking many questions again and again, having habits that to chew or spit and things like that. So you break the cycle by giving them things to do. As to whether there's a drug, well, if there's a drug, it might make them drowsy, then they'll stop spitting or doing anything altogether. So it's quite a difficult thing. I must confess, it's quite difficult. And I'm really sorry if you're going through this. I know it must be very, very challenging, Tina.
Okay, we will have a final question now from Joe. Will dementia drugs have any significant side effect that caregivers need to be aware of?
Certainly, any drug would have side effects, and any drug you give may have interaction with other drugs that the person may be on, as well as food that the person may consume. So there are right now 2 classes of drugs for dementia, and the other are mainly antipsychotic drugs. So they are used to treat behavioral symptoms of dementia. So the dementia drugs, if I get you correctly, would be things like Aricept, donepezil, or Exelon or rivastigmine. And the other class so that's one class, and another class is things like Ibixa or Memantine, Memantor. So one of the commonest side effects of these dementia modifying drugs would be loss of appetite, nausea. Some people get very, very, very nauseated and they vomit. Some of them may lose their appetite. Some of them may have diarrhea. Some of them may have gastritis. So there's a lot of what we call gastrointestinal side effects. And then there are others where it affects them neurologically, so it makes them either very, very sleepy or very, very agitated. So if any of these things happen, you need to go back to the doctor that prescribed you the medication to discuss whether it should be reduced in dose or stopped or replaced with something else. Now, another more sinister side effect of these dementia drugs, especially if there's underlying heart disease, is it can cause conduction problems in the heart. So it can slow the heart rate down. It can affect the conduction of your electrical impulses in the heart, and even cause what we call heart block and cause low blood pressures, etc. There's a very small percentage of people have that, which is why before starting any dementia drug, or your responsible doctor should do an ECG, check that the baseline rhythm is okay, and then after a month or two on the drug at the optimum dose, check the ECG again to make sure there's no signs or changes to that ECG. That's something that we have to be very vigilant about. And if the doctor that's prescribing you the drug is not doing so, please remind them that it is something that often we see at memory clinics. This is often those who get prescribed the drug outside of our service. They're not checking these things, and it is very, very important that we do so.
Okay, I think all the questions has been answered. Okay, thank you. I'm so sorry we can't take any more questions. Thank you so much for the knowledge and useful information regarding dementia. On the behalf of Homage, I would like to thank Dr. Shahrul Bahyah for being willing to spend some time with us to unravel the differences between mental illness and dementia. The health information is provided for general information and educational purposes only, not substitute for any inpatient professional health advice. To seek further medical advice for your medical condition, to consult your doctor or go to the nearest health institute to get assistance. This video only represents the speaker's views of mental illness and dementia. Thank you, everyone. Have a nice day.
Thank you.